So we're almost done for the semester. Can you all believe it? We've got basically a week and a half. We have 3 lectures today, Monday, and Wednesday, and then we have our final. So let me talk a little bit about the final, just to remind everybody. So the final is really more like an exam 5. It's probably about 80% plus or minus, maybe 3 to 5, 80% over the new material. So 80% of the questions are going to come over 3 lectures on special senses. Okay, very doable. And then the 20%, upwards of 25%, but no more than 25%, probably 20% plus or minus a few percentages, is over cumulative material, over units 1 through 4. So it's really not a cumulative final. It's going to have a little bit more cumulative questions than your last exams, but the vast majority of it's going to be over the new material. Is that clear? There will be a bonus number 5 opportunity sometime next week. It'll happen just like it does with all the prior exams. We'll have a bonus 5, we'll have an exam 5, and then we'll have an exam 5 total, which will be the combo of those. Now, let's talk about dropping the lowest exam. You don't have to pick it. I've had a few email questions, and I tried to respond. There was a lot of traffic. I'll explain here on email in a second. There was a lot of traffic over the last couple of days. So I just haven't had a chance to respond to everybody. So hopefully, if your colleague isn't here, they're watching the video feed, and they'll get their questions answered. And I didn't get an email out to you, but I answered it in the lecture. The lowest exam will be dropped automatically. So if that's exam 1 for you, or if that's exam 4 for you, then that exam didn't even count. And you're going to want to take the final, the 5th exam. If you did really well on exams 1 through 4, and your Canvas grade you feel confident in, and you've double-checked it, I would double-check it if it was me, my grade, that it's calculating correctly, you don't even have to show up for the final if that's the one you're going to drop. But you will not be able to use the bonus opportunity for exam 5 if you don't take exam 5. You with me? The bonus only counts to the individual exam. So you don't get your cake and eat it too. You can't drop exam 5 but also get exam 5 bonus. It just doesn't work that way. If you have questions about your grade calculation, come see me in office hours next week and let's go over it together. Because you don't want to make an assumption on exam 5 and you Canvas calculated wrong, or you calculated wrong. I mean, I would double, triple check. You with me? I don't have time to calculate manually 180 grades and verify with you. But if you come and see me, we'll do it together. Okay? I know it sounds complicated math, but it's really pretty straightforward math, right? You can look at the syllabus, see the total number of points. I'll walk you through this real quickly. So the total number of points in the class are 550 points. So where do they come from? There's 5 exams, 400 points from 5 exams because you drop one of the lowest exams. 100 points comes from the quizzes. There's 12 quizzes, but we dropped the 2 lowest. So there's only 10 that count, 10 points each. That's 100 points. Now we're at 500. The other 50 points come from the participation activities. That's coming to class, that's going to a review session. Those are 5 points each, 10 points per unit. We've had 40 of those. We'll have 10 more for the last unit. That's your 550 points. So you take 550 times, if you're trying to earn an A, notice how I said earn an A. If you're trying to earn an A, it's 550 times what? I know, it's like, Keller, this is not math class, dude. 550 times 0.895 will give you the total number of points that you need to earn an A. Because 89.5 and above, we round to an A, correct? According to the syllabus. 550 times 0.795 is what you need to earn a B. So on and so forth. So that's how you'll calculate that. Nothing secret about it. There's no fancy curve at the end. straight scale, bonus opportunities. Any questions on how that plays out over the next week and a half? Okay, exam 4. We had a little key mishap. So if you were looking at the grades before I sent the announcement out that they were ready, you might have had a panic attack like me because we graded a vast majority of the class with the wrong keys. And then we had to correct them. And so if that was you and you sent me an email in distress, we actually had to correct that. Okay, so thanks for all the extra work. A lot of them were hand graded because when you run them a couple of times through the Scantron, it's illegible. So we got that all sorted out. The exam 4 total score is correct, and that's posted on Canvas. And so your Canvas score to date should be accurate. Okay, so hopefully that explains the last like 48 hours if you were like caught in the middle of that and wondering, how did that possibly happen? Okay, this week in lab, looks like you're taking your final, or turning in your final, and we're in special senses, so we're kind of wrapping up the semester about where we were, where you were in lab. And the last section that we have on special senses, I think, is one of the most straightforward materials because it's sort of the culmination of everything that we've learned. There's a lot of things that we'll talk about with respect to nerves and signaling and receptors and interpretation. And a lot of this, I think, is really kind of fun now because you have all this background information that you can pull upon and you actually can track with what we're talking about. So I think this material tends to be the most straightforward, and the scores on the last exam tend to be the highest averages that we have all semester. So if that's you trying to make these calculations of, okay, I'm dropping my lowest, I really need to earn this on this exam to get this in this semester, this is the exam to do it. Okay? That's my encouragement to you. That's my pep talk. Hopefully that makes sense. And if that's not enough, go study outside because it's beautiful right now. Speaking of beauty, what is a frog's favorite kind of flower? A crocus. I thought that was pretty obvious, but okay. What do you get when you cross a vampire and a teacher? Blood tests. How do you have a successful solar system party? You plan it. Nicely done. You plan it. Okay. So today, time allowing, we're going to go through this first lecture, and we may start the special senses on taste. We'll see how far we get. Okay? So right now, we're going to launch into the special senses by first talking about general senses. And what we're going to do today in the first part of the lecture is we're going to compare and contrast general and special senses. And the senses in general, or the senses collectively, I should say, the general senses as well as the special senses, are how we interact with our environment. So they're actually really important to us as a species, as an organism, as an entity in a living world. This is actually how we interface with our outside environment. So it's something that's actually rather critical. And as the lectures go on over the next week and a half, and as we kind of get into the activity that we're going to have for the bonus opportunity, a lot of times we don't appreciate these things until one of them's gone. Right? There's an injury, and you lose feeling in that fingertip, or you lose feeling in that toe, or unfortunately, you lose vision in that eye, or you lose hearing. Like when these senses disappear is when we actually really start to appreciate them. You with me? So kind of keep that in mind because there's a population, maybe some in this room, but definitely outside of this room that many of you are close to, where this is, that's a real thing. That has impacted people that are close to you. So as we study this stuff, know and understand that, hey, this isn't just material. This is how we interact with our world. This is how we appreciate the world in some cases. And your future patients, if these things are compromised, that actually brings a lot of distress. Even more distress than accidentally grading the exam on the wrong key, okay? Wait, too soon? Sorry. So sensory input is critical to our personality and our intellectual function. Sensory input. So pediatric medicine, right? We have all these milestones. Probably few of you are parents, maybe some are. Maybe some of you are aunts or uncles. But all of you have seen infants and you know, okay, new parents are crazy. It just happens. And now all of a sudden there's this baby, this infant, and their whole world revolves around it. And all it does is eat, poop, and scream. And they do everything they can to make sure that their sensory input modifies their intellectual function. Let me give you an example. Books, right? Talking, cooing, cuddling, hugging, kissing, smelling their head, putting a mobile over their crib, having toys, even though these kids don't even move yet. They're like surrounded by all these toys and stuffed animals, right? All of that is sensory input for the developing infant. And parents take it extremely serious, right? That'll be you too, if it isn't already, or if you're an aunt and uncle or an uncle, you understand. So when that is actually compromised, we see developmental delays in infants. And that's why if you're going to be a nurse or a PT, occupational therapist, physician, and you're going to be in pediatric medicine, that's why these milestones are so critical, right? And there's industries, huge industries associated with these types of sensory input to make smarter kids, essentially is what that says, right? But it also shapes our personality and who we are and how we see the world. It's that nature versus nurture. That nurturing at a young age impacts some of the choices that you make. And there's a lot of discussion around that. There's a lot of controversy and there's a lot of opinions, but we know for the most part that's all real. And depending on where you fit in some of those conversations, we won't talk about those things because they're, personal, but it's a real thing. And the take-home message is it shapes who we are. So this information that's communicated by these sense organs, sometimes it never even comes to our conscious mind. Like you don't even pay attention to it. Some examples here: blood pressure, body temperature, muscle tension. What measures muscle tension? Golgi tendon, thank you. Right? These are things that we've learned about this semester that now we can appreciate. So yeah, I do interact with my environment, with my Golgi tendons. I don't think about it like, ooh, that Golgi tendon is going crazy right now, right? But you do respond with, oh, that's too far. I felt like something was about to pop. I'm glad I backed off of that activity or that movement or that exercise or just picking up that pencil off the ground or whatever it is. The sense organs initiate somatic and visceral reflexes. So somatic being like muscle and visceral being like smooth muscle or cardiac, that are indispensable to homeostasis, meaning you cannot do without them. You will not survive if you don't have them. So this is kind of our setup for today, and hopefully I've convinced you that in this last unit, like all the units, it's critically important for us as an organism. So these sensory receptors, what the heck are they? Well, they're a structure that detects a stimulus, and it has tissue incorporated around it. So, for example, like a nerve ending. We have sense organs, which would be nerve endings plus tissue. And that tissue that surrounds that receptor helps to augment or enhance or modify the signal that you're receiving. So the example that I'll use here is back to the very beginning of the semester. And this is back to the very beginning of the semester, mostly in lab. And what is this structure that I'm pointing to here in the skin? Where am I in the skin on this slide? Am I in the epidermis or am I in the dermis? Where am I? I'm in the dermis. This is the epidermis and this is the dermis. This is the dermal papilla. And this structure is located right in the dermal papilla. What's it called? Do you remember? Corpuscle. There's a name in front of it. Meissner's corpuscle. Meissner's corpuscle responds to light touch. It's a mechanoreceptor. It's encapsulated. It's a sense organ that you've already studied. It kind of has a structure that looks like this if you schematically draw it out. And you can appreciate the nerve that's coming out of the bottom now. Bless you. Right? So a Meissner's corpuscle is a perfect example. A sensory receptor. This is a structure that's specialized to detect a stimulus. This one doesn't have bare nerve endings. We'll see some that do. This one actually has a covering or a capsule. A corpuscle is what we call it. And therefore, it's a true sense organ. Some of this accessory tissue can also include other types of tissue, like epithelium or muscle or connective tissue. So the general properties of these receptors are shown on this screen. And what we can see are, we're going to see three things. So we're going to see transduction, we're going to see receptor potential, and then last what we're going to see is sensation, which is on the next slide. So three general properties of a receptor. So let's just take them one at a time. Transduction. What do you think that means when a receptor transduces something? What does that mean to you? Transfer. Transduce. You're going to move energy from one form to another form. That's it. So this is a fundamental property of a sensory receptor. It's converting energy from one form to another. So it might be a mechanical energy to an electrical signal in the case of the Meissner's corpuscle. So it could be light or it could be heat. We talked about touch. Touch is mechanosensation, right? It could be sound. Now, light and sound we're going to get to next week when we talk about special senses of vision and hearing. But you're taking some signal of energy and converting it to an electrical signal. That's transduction. So the sense organ is a perfect example of that. Well, the gasoline engine, the electric motor, the light bulb, these are all transducers. Your cell phone, your tablet, your computer, you as an organism, you're all transducers. Right? You consume energy, create ATP, and then use the ATP for movement or activity or contraction or fill in the blank. So all a transducer is taking one form of energy and converting it to another form. Make sense? Okay, number two, a receptor potential. When I say the word potential, what does that mean to you? Somebody tell me what a potential is. After the last unit, we just got done with it. What's a potential? Well, so the capacity to complete an action, it's the capacity to change an electrical impulse. Okay, that's what. Do you remember an action potential? Right. So an action potential is just a change in an electrical signal. So a receptor potential is a small electrical signal on a receptor that's initiated by some stimulus, light, pressure, sound waves. Okay. And then it results in a release of neurotransmitter activity that sends action potentials as nerve signals to the central nervous system. That should make total sense. So that's number 2. The last one is a sensation. Characteristics or properties of receptors. So the sensation is the awareness of the stimulus. So most of these signals that are delivered to the CNS, when we talked about the CNS, they produce no conscious sensation. Why? Where do they go in the central nervous system? What spot? What location? Cerebral cortex? What do you think? Yes or no? No conscious awareness. Cerebral cortex? No. Temporal lobe? No. Parietal lobe? May stop there or have a location there. But if there's not conscious awareness and it's automatic or autonomic, where do you think in the central nervous system it primarily goes? If it's not high, it's where? Probably low. So where low in the central nervous system of the brain would you expect a lot of these sensations to end or terminate? Medulla, brainstem, pons. Yeah. The inferior portion of the brain. That's where we had cardiac reflex centers, respiratory centers, right? So a lot of these sensations that we're not consciously thinking about, like what's your heart rate, what's your blood pressure, they're going to the brainstem. That's exactly right. pH and body temperature. Not necessary for us to be aware of that. Like, what's your pH? Your phone, your iPhone doesn't even tell you that, nor does your Garmin watch what your pH is. Right? It's just your brainstem that does that. Okay, 3 properties. So now what I want you to do is you can work together. I want you to compare and contrast general senses with special senses, like characteristics of each and then location of each. So fill out that chart. Or if you don't have it printed, just find a scratch piece of paper, make a simple box with like 6 boxes, or I guess 4. But on this side, you're labeling characteristics and examples and location. And up top, you're labeling general senses and special senses. You work together if you want, no problem. All right, let's start with general. What are some characteristics of general senses? Characteristics of general senses. Any ideas? General senses. Let's go.
Are they usually like we have unconscious awareness about them?
General senses can be unconsciously aware. I would agree. What else? How about where you might find them? Would that be helpful? Where do you find general senses? Like the Golgi tendon. Is that a general sense or a special sense? It's a general sense. So where is it located? Only in the big toe? Where? Throughout the whole body, right? General senses are found throughout the entire body. Sometimes they're very simple. The receptors are simple in nature. Like it could be just a bare dendrite. What are some other examples other than Golgi tendon? What's an example of an unconscious one that you are thinking of? We've talked about a few. pH receptors. Pressure receptors. Thank you. What else? Temperature receptors. Great. You guys are doing great. You're catching on. What else? Pain is a general sense. Does pain only happen in the example of tooth decay? Pain only happen when you tear your ACL? Pain is a general sense. Okay. Special senses. Maybe this will be a little easier. What are some characteristics of special senses? An example would be taste, I agree. Touch is a general sense. They're more complex. Let's start there. General senses are simpler. Special senses are more complex, for sure. An example would be taste. What's another? There's 5 special senses. I'll give you a hint. What are the other 4? Vision, smell or olfaction, hearing, sound. What do we get? Taste, smell, vision, hearing. There's one more. It's in the inner ear. Balance, equilibrium. Thank you. Where are they located? Are they everywhere? You know, when I meet you, do I walk up to you and be like, right? Am I sniffing to see who this is? Where are they located? Not all of them are in the nose, but the one that I was example. Yes, yes. Where are they? They're within the head. Yeah. So that's kind of an interesting concept to think about, right? Like, can you imagine if you interacted with the world with chemosensation? That's what smell and taste is with your hand, and you're like, right, sniffing around. That would be weird, but everybody would do it, so it wouldn't be that weird. It's just weird because I'm doing it. So complex, simple, head everywhere, right? Sometimes unconscious information. Over here, wow, some really unique types of sensations with special senses. Vision, not just vision, but color vision, black and white vision, night vision versus bright light vision. Sound, not just high pitches, but low pitches. Different intensities. You have sound recognition, right? You can discriminate your best friend calling your name versus some rando that you don't know who it is. Right? Certain special smells. Your favorite meal. How many went home for Easter? A few? You know, maybe you walked in the house and you're like, oh, good, we're having that meal, right? So how we interact with our environment, the senses. But we've got special senses versus general senses. Okay, let's talk about this transduction or transducer of energy. So I want you to partner up real quick and give some examples of transducers that we haven't talked about yet, each of you. I just want to drive home this point of transducing energy from one form to another. So let's see what we can generate here. Ready, set, go. Does not have to be in the body. I don't need a formula. I just want you to shout out an example when I ask for it. What are those called? I love it. I love it. Okay, let's hear some examples. Some examples of transducers. Not a miser's corpuscle. What are you thinking about? That is an example of a transducer, but a miser's corpuscle. But give me some other examples. Photosynthesis. Yeah, very good. Light energy to ATP. Great. Digestion. Yeah. So you're going to take basically a bolus of food and extract from it its caloric energy value. Yeah. What else? What's the obvious one on this picture? Oh, solar panels. Thank you. Yeah, I was trying to give you a hint. Solar panels. Light energy to electricity. What else? Let's stay on that theme. Hydroelectric. What else? Like a dam up at Lake Powell or Lake Mead. Yeah. Wind turbines. Perfect. Wind energy. You know, wind blows, turns those giant turbines, makes electricity. If you drive from here to California, you see lots of them. What else? Heating pads. Yeah, a heating pad is you're putting electricity through wire, and you're doing it in an inefficient, uninsulated fashion, and it creates heat. That's how if you're fortunate enough to have heated seats in your car, that's exactly what's happening. You push the button and warmth comes out, right? Water turbines, yeah. What else? Some other examples of transducers, taking one form of energy to another. Absolutely, a radio is absolutely one. A speaker, a cell phone, right? I mean, these squawk boxes, if you use them as a phone, right? Sound comes out. This microphone, right? Transducer. The projector, transducer. So that's all we're doing here with receptors, is we're taking one form of energy and converting it to another form of energy. Are you with me? Pretty straightforward. We don't need to make this more complicated than it really is. So the general properties of receptors, there are 4 that I want to chat about. Modality, location, intensity, and duration. So modality is the type of the stimulus the sensation produces. Does the sensation produce a vision or hearing or taste or muscle tension? That's the modality. Secondly, the location. It's encoded by fibers that are sending signals to the brain. And which fibers are those? What location are they found in? Is it a cranial nerve? If it's a cranial nerve, it's probably going to be associated with a special sense. If it's coming from the periphery into the spinal column via afferent fibers from the dorsal aspect going up to the brain. Do you guys like that question that was on the exam? I mean, we've been waiting for it, right? Okay. The intensity. So the brain can distinguish intensity by a couple of different things. Number 1, which fibers are sending the signals, how many, and how fast. And that's what we decipher as the intensity. So take pain, for example. Pain is a great example for a sensory receptor and for proving my point that we need the ability to interact with our environment to stay alive. If you didn't have a pain response from certain things in your environment, you would not exist. Is that you with me? You would touch the stove when you were an infant, not realize that it hurt, and you probably wouldn't make it much longer in life. So we adapt by interacting with our environment. And so pain is actually one of those natural, very well conserved, evolutionary speaking, pieces of sensory input that motivates us as an organism, right? And animals do the same thing. Something gives them pain, they stop doing it. They move to a certain area, there's a pain response associated with it, they stay out of that area. Duration, how long the stimulus lasts. So modality, location, intensity, and duration are 4 general properties of receptors. Okay, let's talk about receptive fields. So when we think about the way the body is set up, there are certain places where it's probably more important as we interact with our environment that we have closely discriminating capabilities. Like we can really detect, okay, where is that pencil, right? And I'm trying to find the pencil here on the podium, and I can't, I found it now. Well, I didn't just use tactile feel. I actually looked real quick. But the receptive fields on the right are small receptive fields, 3 separate neurons that are capturing mechanosensation from the skin, happens to be on the hand, and that's giving you, with a small receptive field, more information per unit area. So we see that with, do you remember the homunculus in the brain? The map of our sensory input from the body, and the hand and the face had lots of sensory input, and the back of the shoulder, like what's shown here, or the trunk or the torso or the upper leg, it was represented on the homunculus, but not as much real estate in the brain was designated for sensory neurons coming in to the central nervous system on the postcentral gyrus for the scapula. Because you're not going to try to find the pencil on the podium by rubbing your shoulder over it, right? To try to tell, oh, no, that's the microphone. No, that's the projector. Oh, there's the pencil, right? You're going to use your hands. So the small receptive field and the biologic energy necessary to develop many, many neurons in a smaller area is expensive. So you save it for places where it makes a difference. We interact with our environment so much with our head and face, our facial expressions, right? Our body language, our ability to smell, our special senses, our ability to taste, our ability to see. So a lot more receptive fields, small receptive fields in the hand, on the face, larger receptive fields, less discrimination in areas where it doesn't make as much of a difference. Okay, whoops. If we classify these receptors, we can classify them by modality, what started the stimulus, or how they're distributed. And some of this we've already kind of talked about. So by distribution, we already covered. Distribution is either general or special. General, we call it somatosthetic senses, widely distributed. Special senses are limited to the head, and we have them listed here. So we already covered the distribution today. If we move up to the middle one, the origin, it could either be outside the body or inside the body. If it's outside, it's called an exteroreceptor, like exterior. If it's inside the body, it's called an interoreceptor. The third category is proprioception, and this is like sensing body position and movement. So the example here is you are navigating from your bed to the bathroom in the middle of the night and it's dark. And you're navigating and you're feeling your way around. Well, you kind of know there's a step down to the bathroom. And you can imagine and predict so that you don't trip when you step down into the bathroom. You're like, who has a step down in the bathroom? Just relax. It's an example. Probably nobody. Okay? And you step down into the bathroom and you don't trip because you remember and you have that proprioception, that perception of body position and space that I need to step down. That's what proprioception is. Okay, giving you feedback about where your limbs are in space, even though you can't visibly see them. So that's the middle one. The top one on modality is how the information is captured. A thermoreceptor detects temperature. A photoreceptor detects what? What do you think? Light. Nicely done. A chemoreceptor, I'll come back to nociception. Chemoreceptor detects what? Chemicals. Thank you. A mechanoreceptor detects what? Force, pressure. Meissner's corpuscle is an example, the way we started lecture. A nociceptor, I skipped that one. What's that detect? Nociceptor. What's that? It's a special receptor that detects pain. We have a specialized, that's how important pain is as a survival to the species. We have a special receptor to detect pain, just like we have receptors that detect chemicals. So photoreceptors, we're going to get there next week. What special sense is detecting photoreceptors or has photoreceptors? What special sense? Vision. How about chemoreceptors? What special sense? Thank you. Smell and taste for both of those. I know you guys had this in lab. This is great, though. So we'll see how this plays out by these different types of modalities. Did you have a question?
Yeah, I got it.
Okay. So let's shift gears a little bit. We're going to talk a little bit about organization of these receptors. And then as we kind of wrap up this portion of the lecture today, we'll finish with pain. We have a lot of time to kind of designate to talk about a pain response because it is really important. And for those of you that are going into healthcare, I mean, that's one of the biggest things that you're going to be navigating with your patients is discomfort or pain, right? And it's a good thing I wasn't a physician because like my answer would be, or my response would be, so doc, yes. So it hurts like when I do this. Okay, well, stop doing that. Okay, so that'll be my answer. I mean, I'm not wrong, right? But hopefully you'll have a better answer as you move on. But knowing and understanding what gives pain and appreciating the different types of pain, we'll get there, I think will be really insightful for your future. So before we get there, we got to talk about how these things look and are categorized. And so we've got unencapsulated nerve endings on this slide. Unencapsulated nerve endings. And then we're going to talk about encapsulated nerve endings. But the unencapsulated ones, these are free nerve endings. They include tactile discs and hair receptors. So you can see in this upper panel that's circled or boxed, if you will, that we're talking about these free nerve endings. And I'll just put this next slide up so you can see them, and then we'll come back to the slide. So these are unencapsulated. Free nerve endings, which is pretty obvious, but tactile discs as well as the hair receptor. And believe it or not, that hair receptor doesn't just like make the hair stand up when you get cold or you get frightened. It gives you feedback about your environment, right? It lets you know, oh, I forgot to put my pants on this morning because the hair receptors down on your legs are telling you there's no pants on, right? Or your shirt. No, but think about it out 10,000 years ago when we weren't sitting on upholstered chairs, right? And you're navigating through geography. It's going to give you feedback about your environment, stuff that brushes up against you, okay? So these unencapsulated nerve endings, these three are what we show in that top boxed diagram. And so the three that we're going to unpack here, free nerve endings are how we set up for pain reception. Pain and temperature, skin and mucous membranes. Those are all free nerve endings. The second category, the middle one, tactile discs. These are for light touch, like Merkel discs at the base of the epidermis. And then lastly, the hair receptors that we just talked about, they wrap around the base of the hair follicle and they monitor the movement of the hair. So our free nerve endings in the skin, our tactile discs also at the epidermis, and then the hair receptors. These are unencapsulated nerve endings. Encapsulated nerve endings, so on this diagram, we're down here on the bottom two rows. We've got 6 different types. Here's our Golgi tendon organ. Here's our muscle spindle. We've already talked about these. But these are both examples of encapsulated nerve endings that you're already familiar with, right? It's kind of nice that you kind of see where a lot of the stuff that we learned all semester is kind of coming together. You can see some other, like the Meissner's corpuscles or tactile discs, end bulbs, bulbous corpuscles, laminar corpuscles. These are dendrites that are wrapped by connective tissue or supporting neural tissue, glial cells. And that connective tissue enhances the sensitivity of the response. So these encapsulated ones, the tactiles or the Meissners that we started the lecture with, light, touch, and texture. They're at the dermal papilla. The cross end bulbs, tactile or touch and mucous membranes. The lamellar or Pacinian corpuscles, these are deep pressure. These are found in the deep dermis of the skin or in the periosteum of the bone. They detect pressure in the sense of force, stretch, vibration, even a tickle response. So these are the ones that are responsible for the tickle sensation if you're super ticklish. And then last but not least are bulbous or Ruffinian corpuscles. These are deep pressure or heavy pressure, joint movements, and the stretching of the skin. Okay, so how these things are encapsulated or not encapsulated, we'll categorize them. And, the free nerve endings are the ones that aren't as complicated, but they're also critically important for our survival. And I already kind of mentioned, they're well conserved in biology. A free nerve ending is pretty easy to manufacture from a biology standpoint. You don't have all these accessory structures that you have to wrap around it. So even simpler organisms can have dendrites that are free nerve endings that signal a pain response. And there's been some really interesting research on, less complicated organisms that, the question is, do they experience pain? I'm not talking about mammals. I'm talking about simple organisms, insects, invertebrates that don't even have a backbone, no spinal column, right? Do they detect pain? Well, it's not complicated to detect pain. It's a simple nerve ending, and it's critical for your survival. So this is discomfort that's caused by the tissue, injury itself, or some stimulation that's noxious. And it usually leads to some change in behavior. Like, I'm going to stop doing that. I'm going to not touch the stove because it's hot, and my hand hurts for 3 days after I do that. Okay. This also, unfortunately, can be compromised in complex diseases like diabetes mellitus. So let me explain. Diabetes mellitus is a type 2 diabetes. It's usually found in the adult population, most typically. And there is a high association with obesity, but they're not completely correlated. So individuals that wrestle with type 2 diabetes may or may not have obesity on their medical history, but there is a high correlation of, in obese patients, a lot more type 2 diabetes. Does that make sense? This tends to be considered the one where you become insulin independent, like you are insensitive to the insulin that you manufacture. So you still make insulin, you just don't respond to it. So now you have high amounts of sugar, glucose, that are in the bloodstream instead of in the cells where you need the energy. So the blood is flowing with a lot of extra sugar. That sugar coats the blood vessels. It causes lesions to take place. So think about a pipe that has a nice watery substance flowing through it, and then you replace it with something that's more viscous like honey. If you increase the sugar content of blood, the viscosity goes up. So the blood doesn't flow as easy. It does create lesions on the inside of the blood vessel. It leads to a vascular disease. You prevent blood flow to the distal extremities. This happens over decades in a patient. And when the blood flow in the distal extremities is decreased, the nerves starve of oxygen and die. And that's called diabetic neuropathy. You have experienced this in its early infancy. You've sat in a position and your foot fell asleep. That's called parathesis. That is the nerve telling you that it's starving of oxygen. So that's that pinprick feeling. So what do? You uncross your legs, you shift in your chair, you change your position, you stomp your feet, you do whatever you do, right? And you're like, oh my gosh, it's going to sleep. And then the pinprick feeling subsides. But in patients with diabetic neuropathy, that pin and needle feeling all day, 24/7. Does that sound horrible? Yeah. So that's their nerves are starving of oxygen. So what we'll do, we'll prescribe medication that numbs the nerve so they can't feel that anymore. But the basic problem is a diabetes issue. And so now, where am I going with this? Well, where I'm going with this is a lot of patients with diabetic neuropathy can't feel their feet anymore. And so they get wounds or they step on a carpet tack, they stub their toe, a little cut opens up. They don't know about it and it won't heal. And they get diabetic ulcers on their feet. And they become infected. And then it's very common in late unmanaged type 2 diabetes, mellitus, with diabetic neuropathy for a long period of time, they have to amputate that toe, foot, lower limb. All because they can't feel pain coming from the distal extremity to know that if they never cut their foot, there's no problem. But they end up getting these lesions on their feet, okay? So it's like my example of how losing the pain response as an organism is not a good thing, right? And here's an example of how it manifests itself probably in your future patient population, because diabetes mellitus is on the increase. In Western culture, it's on the rise. Probably because our diets are getting worse and our exercise is getting less, right? Was there a question over here? No question? Okay. So nociceptors. They provide pain in two different modalities. So we've got fast and we have slow pain. Now, you tell me, look at me and tell me if I asked you that question. Don't look at the screen. Fast pain travels how versus slow pain? How do you think on a nerve? Which nerve is going to send a fast pain signal? Which kind of nerve? Thank you, a myelinated nerve. I mean, you literally just remembered something from what you learned this semester, right? And slow pain travels via an unmyelinated nerve. So let's look at the data. Myelinated nerve fibers, fast pain, 12 to 30 meters per second. That's a sharp, localized stabbing pain preceded with injury. Slow pain, unmyelinated fibers, 0.5 to 2 meters per second. Longer lasting, dull, diffuse feeling, usually like abdominal tummy ache, abdominal pain. Sharp pain when you break a bone, tear a ligament, right? That's that sharp stabbing pain. Myelinated axon. Happens quick. You're like, oh dang. Versus like an upset tummy is kind of like, it's dull and it's diffuse and it's kind of hard to pinpoint, right? And if you're going into pediatric medicine, good luck, right? It's like, where does it hurt, little Johnny? Right here, right? And they just point everywhere in their belly.
Is pain like if it's like if you did like break a bone, does it start as like a fast and then
Yeah.
goes
It's a
to slow over time?
Great question. So, can it convert? Like if you snap a bone, is it sharp stabbing pain and does it convert to a dull pain? Absolutely, because you're going to have tissue trauma that's in the periphery and that dull pain will continue. You see that with surgery, right? The day after a surgery, there's some dull pain, a couple of days, and it starts to subside. And they always will tell you, let us know if the intensity goes up, if it becomes a sharp pain. But if it's a dull pain, they're probably, it's going to fade. That's why a lot of that instruction on post-surgical instruction with pain management, those instructions are given. Yeah.
Does sharp pain have to be fast, or like what if you have a patient that has sharp pain that lasts hours to days, so they'd be longer lasting? Could they be interconnected like that?
Yeah, sharp pain doesn't mean that it's fast and it goes away. It could be fast, sharp pain that's long lasting, unfortunately. Yeah. They're not necessarily mutually exclusive. I'm just telling you, the slow dull is the unmyelinated fibers, which you all kind of, the light bulb went off. You're like, okay, that makes total sense based upon what we learned. So somatic pain is from the skin, muscles, and joints. Visceral pain from the viscera, right? Like the abdomen or the thorax, the chest. The visceral pain usually is coming from some kind of stretch or chemical irritant. It's poorly localized, and that's why abdominal pain is so difficult to figure out, because it's very diffuse and kind of all over. Sometimes you can tell if it's high versus if it's low, if it's appendicitis versus a gallbladder, right? It might be sited on the body versus gallbladder pain's a little bit higher, but they're both dull pain. Gallbladder pain usually corresponds to like after a fatty meal in a patient, because the bile is there to help emulsify the fat. So after a fatty meal, they usually have more dull pain that's kind of higher up, versus appendicitis is usually sited on one side of the body. The injured tissues release a lot of different chemicals. These chemicals make us aware and stimulate these receptors. Bradykinin is one of the most potent pain stimuluses that we know. And the tissue that's traumatized will release these chemical mediators to tell the body, hey, there's something wrong in this spot. Okay? And you should probably not use this spot because there's damage here and we need to heal it and clean it up. Histamine, prostaglandin, serotonin also stimulate pain receptors known as nociceptors. Now, if we look at projection pathways for pain, they're not always direct, which also makes diagnosis a little challenging. So referred pain, like pain in the viscera, like in the abdomen, can also be mistakenly diagnosed as coming from other, skin locations or a superficial site, because you've got these convergences of the neural pathways in the central nervous system. And the brain is kind of assuming that visceral pain is coming from the skin. So it's a little difficult to kind of pinpoint where referred pain is coming from. So another example would be in patients that experience a heart attack or a myocardial infarction. Oftentimes, there's pain felt in the shoulder on the left side, and there's down the left arm, like shooting pain to the spinal column from thoracic segment T1 to T5. And, the reason for that is shown on this slide, that the reason for that is the heart and the sensory pain receptors that are shared by the left upper quadrant of the thorax are also shared with the medial aspect of the left arm. And so in patients that have a heart attack, oftentimes they're getting pain response in their left arm, not their right side. It's just the left side, and that's typically a tip-off on a 911 call. It's like, hey, so what's going on? Well, they're complaining that They have shortness of breath, and their left arm has pain in it. How old's the patient? Do they have a history of heart disease? They're on medication with blood pressure medication. We're sending the ambulance right away, right? So you can kind of see the different regions on the anterior versus the posterior aspect of these different pain centers. And visceral pain is often mistaken as coming from a superficial location. A superficial location. This also happens to be an overlapping chart with a lot of Eastern type of medicine to treat pain. So for example, like acupuncture. So there is some science associated, some Western science that can be linked up to Eastern medicine on certain aspects, especially like pain. So the other one that we've known about in Eastern medicine for thousands of years are these pain receptors and how to trick them. How to develop a natural analgesic, which is a word that says an anti-pain medication, that's topical. And so what happens is this damaged tissue is going to secrete signals, bradykinin, histamine, or prostaglandins, that will stimulate the nociceptors. The fast pain, the first pain is typically sharp and stabbing. The second pain is usually dull and more diffuse. But again, they are not necessarily mutually exclusive. So how does Tiger Balm, Icy Hot, BioFreeze, right? How do these menthol-based patches, and this all comes from Eastern medicine, how does this actually make my muscle stop aching for a while? And older patients love this stuff. When I say older patients, I mean people 50 and over. I speak from experience. So how does this work? Well, so what's going on with these menthol-based topical analgesics is that the sensations of hot and cold temperature actually travel through nerve fibers adjacent to pain fibers that go to the brain. And they travel faster via myelinated pathways. So the signal of hot versus cold gets to the brain first. The brain interprets that. It's such a loud signal that by the time the pain response gets there, the brain is confused and really only interprets the hot-cold temperature and not the pain. Once the menthol wears off and the hot-cold deception to the brain fades, then the nociception signal gets through and the pain comes back, and then you rub some more menthol-based cream on top of the muscle. Is there anything dangerous about it? No, as long as you don't get in your eyes and don't eat it. But it actually really provides some relief. Are you fixing anything in the patient? No. But is it better than taking Tylenol or ibuprofen? Maybe. Okay. But that's how the mechanism of action works. So is there science behind it? Yeah, there is. And we've been doing this as a species for thousands of years in Eastern medicine. Okay, what causes these different pain intensities? What causes these different pain intensities? Well, the frequency and the number of nociceptors that are firing. That's the main one. The higher the frequency and the number of pain receptors that fire. The central nervous system does have some analgesics, some pain medications that it exogenously produces on its own, or endogenously produces. These endogenous opioids are anti-pain medications, if you will, like enkephalins and endorphins. These are natural occurring that we make ourselves. You've heard about these things. People can work through the pain in extreme circumstances. There's, 100-pound mom picks up a car because it is pinning her baby in a stroller against the wall. And all these, onlookers are like, how did that mom do that? I don't know how 5 men would have done that versus one man. And that was a 100-pound mom, Like these natural and endogenous opioids are extremely potent. And under extreme circumstances, they can be secreted by the central nervous system. And they prevent the first order neurons from making the neurotransmitter that stimulates nociceptors. And it's called substance P. Substance P. So let's look at this picture here. Here's a little pain setup with a candle and a finger. And the nociceptor is sending a signal. Here's the dorsal horn of the spinal cord, because that's the posterior aspect where sensory input comes in. We all know that now. And you can see that number 1 innervates onto number 2. And substance P is this green neurotransmitter that's at this junction. It's sending the signal to number 2, the second order neuron that goes up to the spinal thalamic tract, to the thalamus in the brain, central nervous system, to number 3, to the cerebral cortex, down to the midbrain. Hypothalamus gives some input, like I'm really angry about that feeling, right? That sucks. Usually you get a pain response, you're like, dang it, right? Because the hypothalamus is like, you moron, why'd you do that, right? So you have some sort of emotion associated with the pain, like, again, I cut myself again on this stupid piece of paper, right? I don't know why paper cuts hurt so much, but anyway, so down to number 4, down to the medulla oblongata, the reticular spinal tract, down to number 8, and this negative is releasing an inhibition, as number 6 and number 7 are releasing inhibition via enkephalins and serotonins. These enkephalins are these natural pain mediators to prevent this signal going to the brain. You don't stop the pain information coming in. You inhibit the neurotransmitter from being released onto the second order neuron. So that's how you block the pain. Long distance runners. Any long distance runners in the crowd? Know what it's like to kind of get that runner's high? You hit that certain point in your run and you're like, I was hurting like a minute ago and now I don't hurt. That's because your body has decided, okay, this activity isn't stopping and I just need to, buck up and get it done. And so you release that to fight through the pain. So that's real. That's a real response. Questions over today. So what I'm going to do, we have a few minutes. I am going to introduce our next lecture, and we'll pick it up here on Monday. But I want to start into special senses, and the first one that we're going to talk about is taste. Okay? So taste. It's also referred to as gustation. And this is a sensation that results from the action of chemicals on chemoreceptors, like we just talked about, that are on taste buds. We've got 4,000 taste buds, mainly on the tongue, that are in the buccal space or the mouth. We have a total of 10,000, so about 6,000 more, that are located in the inside of the cheeks, the soft palate, the pharynx, and the epiglottis. So the cheeks, the top of the mouth, and the back of the mouth. And the ones that we tend to focus on are the ones that are listed here on the tongue, or the lingual papilla. Lingual meaning tongue. So the first one that's listed is filiform papilla. And filiform papilla actually have no taste buds, but they give you information about texture of food. So texture of food is actually really important, right? I mean, if you've ever been around little kids and they're experimenting with new foods, we had this happen in my house, right? It's like, hey, you got to try everything. Like, well, I don't like it. Well, why? It tastes weird. What does that mean? I don't know. It's got a funny texture. That's the filiform papilla. Food texture. Fili means thread, and the form is the shape. So they're like thread-like shaped papilla. This is the rough part of a cat's tongue for those cat lovers that the cat might lick your hand. You're like, gosh, your hand tastes like or tongue feels like sandpaper, right? That's the filiform on the rough part of these mammals. I mean, it's the same with dogs if they're grooming themselves. Cats tend to be a little bit more aggressive on the filiform because they groom themselves more than dogs, right? Cats stay really, really clean. And it's the filiform that allows them to groom, but that's their rough sandpaper-like tongue that you feel. The folate, these are weakly developed in humans. Folate means leaf-like. They form parallel ridges on the sides of the tongue. And the prevalence is in young infancy with folate. By the time the child gets to 5 years of age, the folate papilla are pretty much gone. And so it kind of helps to explain why a lot of young kids have sort of like funny taste aversions, probably for protection. So they're not straying out and eating too many weird things. This gives them this extra sensitivity. They don't like a lot of strong foods. But by the time, you've probably seen this happen. There was stuff when you were a kid you couldn't stand, and now you go out with friends and you have peer pressure, and they're like, you should just try it. You should try some oysters. And you're like, oh, gross. I tried oysters, and they were like slimy. It's just like eating snot. And then now as an adult, you try, you're like, wow, those are actually pretty good. Right? So our taste buds do migrate as we age. Fungiform. Fungiform means like fungi, like mushroom type. They're widely distributed, but they're mostly concentrated on the tip and the sides of the tongue. And then the last one, known as circumvallate or vallate, they're at the back. They kind of form a wall at the rear of the tongue, and they contain about half of all the taste buds that are found on the tongue. So the last slide that I'm going to leave you with today that we're going to talk about is this one. And then we'll come back to it after we kind of walk through. But the papilla are not the taste buds. They're the structure. And the taste bud is actually found within the papilla. So if you see this fold, and you can see that the taste buds are found within the tissue that's deep within the papilla. This is a filiform papilla here, and I'm circling, or I'm highlighting a vallate papilla on this screen. So here's a folate papilla here. Here is the histology, and here's the taste bud that's found right here, this like bulbous structure. Here is this bulbous structure blown up in higher magnification schematically. So all these taste buds look alike. They look like a lemon, and there's about 40 to 60 taste cells, and then we have supporting cells and basal cells. So the taste cells are like the neurons. The supporting cells are like the glial cells. And then the basal cells are like what you find in the skin. So they regenerate. So if you've ever had pizza and you're really excited and it was too fast and you should have let it cool off, and now you can't taste anything for like 3 days, and you're like, dang it. And then you do it again like in 2 weeks, and you're like, dang it. And your hypothalamus gives you an emotion. You're like, seriously? Come on. So they'll turn over and make new taste buds every 7 to 10 days. So these taste cells are the ones that are in pink, and the supporting cells are in blue. The pink ones are the ones that have the innervation to the nerve on the back, and the blue ones, like glial cells that we saw in the periphery and the central nervous system, they're just support. They have no neuronal connection. The basal cells are located at the basement membrane, just like we see in the skin, and they're the ones that regenerate and make, thank goodness, because we like pizza, they make new taste cells every week to week and a half, 7 to 10 days. And the taste pore is where the chemical molecule comes in, binds to the hair, triggers an action potential in the taste cell, which sends a neurotransmitter that binds onto the nerve, sends this signal back to the brain. And you know that whole process now because you aced the last 2 units, right? Okay, this is where we're going to pick it up. on Monday. Hope you all have a nice weekend. Enjoy the weather.